Welcome. I want to welcome everybody to UCSF Family and Community Medicine Grand Rounds today. My name is Margot Venner, and I'm incredibly excited to welcome our terrific Grand Rounds team today. The title of today's talk is social policies to address health inequities. It's harder than it looks. And our speaker is Dr. Rita Hamad, joined by Dr. Gabriel Schwartz and Dr. Eva Raphael, who will be our moderators for today. Before we begin, I have just a few housekeeping announcements. I just wanted to let you know that this session is being recorded. And in case you missed part of this session or any of the prior sessions, they will be posted on the UCSF Family Medicine website. You can also look for them on YouTube. For folks who missed some of the prior sessions, all of them are posted, all of those are posted as well. This is a webinar style seminar today, so we'd like you to submit your questions into the Q&A section. Our moderators will select some to answer live and hopefully try to answer some of them or give you ideas of where to get the rest of them answered in the chat box. We are excited to have Grand Rounds the first Monday of every month. The first Friday of every month from 12 to 1 are our Grand Rounds. So we hope that you can join us for the whole series. And if you have suggestions about this particular session and you'd like to give some feedback to our presenters today or suggestions for future Grand Rounds, I'll post some links in there so that you can use the feedback functions. And one last thing before we get started for today, just wanted to remind everybody that the UCSF Family Medicine Rodnick Colloquium is coming up on Thursday, May 27th from 11 to 5 p.m. The invitations and the agenda are being sent out probably right as we speak right now. So you should be getting them soon. We hope you can join us. It will be a virtual format with panels, lectures, and discussion groups, and we would love it if everyone could participate for a robust dialogue. So that brings us to our talk today, which is really going to be terrific. As just a little bit of background information, there's generally positive but occasionally conflicting evidence on the health benefits of social and economic policies to address social determinants of health like poverty and educational attainments. Today, Dr. Rita Hamad will delve into research to understand the possible reasons for these conflicting results, including the possibility that well-intentioned policies may have negative effects. She'll highlight the importance of evaluating the effects of even the most common sense policies in order to inform the design of future interventions and address social determinants of health. Our presenters today include Dr. Rita Hamad, who is an associate professor at UCSF. She's a social epidemiologist and a family physician in the Department of Family and Community Medicine, and also at the Philip R. Lee Institute for Health Policy Studies. She's the director of social policies for health equity research programs and the associate director of the Center for Health Equity. Her research focuses on pathways linking poverty and education with health disparities across the life course, and we're extremely excited to welcome her today. Working with Dr. Hamad today will be our session moderators, which include Dr. Eva Raphael, who's a research fellow in the Primary Care Research Fellowship at UCSF, and also a family physician and a proud family doctor on the Green team in the refugee clinic, as well as Dr. Gabriel Schwartz, a social epidemiologist and postdoc in the Institute for Health Policy Studies. I also want to thank Benjamin Wallen, who's been helping us with the FCM webinars, and of course, Roy Johnston, who keeps us organized and on track with all of these. So with no further ado, I'm going to hand the session over to Dr. Hamad to get us started. Welcome, Rita. Thank you.
Thank you, Margot, and thank you to the organizers and moderators. Let me get my slides up here, and hopefully you'll be able to see them. Oh, my computer's frozen. Are you guys still there?
Yeah, we can still see and hear you, but there we go.
Okay, they're being a little slow. Okay, and can you see the actual slides now, not the presenter view?
Yeah, but it looks pretty zoomed in.
This has happened before, and I don't know how to fix it. It was working just fine in the tech check, so what do you suggest?
Let's go ahead and share it again.
Mhm.
Just try it one more time. Perfect.
Oh yeah? Okay,
Yep.
great. Thank you. Just turn it off and turn it back on. Works for almost everything. Okay, so again, thank you to the organizers and our moderators today. As Dr. Venner mentioned, I'm going to be talking about social policies to address health inequities and how sometimes that's harder than it looks. An overview of what I'm going to be talking about today. First, at the request of the organizers, I'm just going to give one slide that describes my own professional background, especially for those trainees in the audience who might be considering their own future career path. I'm then going to talk about social policies as determinants of health. Next, I'm going to give an example about one specific policy, the Earned Income Tax Credit, which is the largest US poverty alleviation policy for families with children. I'm next going to go through 3 studies that take different approaches to studying the effects of the EITC on health to illustrate sort of the difficulties and the nuances when we're trying to understand the effects of social policies. And finally, I'll wrap up with some conclusions. So again, just to show how I got to my current place in life, here's a quick slide on my sort of convoluted professional background. So I started off getting my undergraduate degree in chemistry, and I knew I was interested in science and social science, but I wasn't sure what career options would let me combine those 2 things. So after college, I did 2 internships at the World Health Organization and then the American University of Beirut, 3, and then also at UCSF. And I discovered and got really passionate about the field of health disparities research. I had a non-MD mentor at the time who suggested that the best way to do public health research was to get an MD, so I did. And at that point, I didn't know that social epidemiology was a thing. Luckily, I attended the UCSF UC Berkeley Joint Medical Program, which gave me the opportunity to complete a research project and a master's degree in addition to the MD. But it was only after I finished family medicine residency at Contra Costa in the Bay Area that I realized I really needed more training to be an independent researcher. I was lucky, I got an NIH Career Development Award while I was a junior faculty member at Stanford, which let me sort of at that time get a PhD in epidemiology. And sometimes I wonder whether I just should have started with that, but regardless, this means that I now sort of have an embarrassing number of degrees, but then I transitioned to be a faculty member here at UCSF, and I've been happily doing 90% research and 10% clinical care since I came here in 2017. So I want to next address the question of what motivates my research, although I'm going to rephrase the question as what are the determinants of health? Usually I get to show this slide in person and I can get audience members to guess at what factors fit into each one of the slices of the pie. But since we're on Zoom, I'll just go through each one individually. I will say though that it's really interesting to ask this question in different settings like schools of medicine versus schools of public health to see people's responses. So first we have clinical care, which makes up, maybe surprising for people at a medical school, 10% of the pie. Genes and biology, another 10%. The physical environment, 10%. Health behaviors like smoking, alcohol use, diet, physical activity, 30%. And then social factors at 40%. So my disclaimer here is that these percentages aren't exact. Of course, there's some overlap between some of these categories, and this figure is based on sort of expert synthesis rather than a quantitative analysis. But these estimates are from the CDC, and others like the Robert Wood Johnson Foundation have published numbers with a similar gist, which is that social factors are hugely important. And so that's what motivates my research as a social epidemiologist and why I examine the effects of social determinants of health disparities across the lifespan. So what do I mean by social factors? I did once have somebody think I was talking about social media. So let's just put that misconception to rest. I do not study Twitter. Although, if you are interested in that, I will direct you to the great work of others at UCSF who work in that realm, like the researchers at PRISM, and especially another social epidemiologist in our department, Toon Nguyen. Anyway, so instead, I'm going to talk about the categories of social determinants using this figure, which some of you may recognize as the social ecological model. These determinants of health range from downstream individual risk factors to upstream macro level policies and everything in between. And the idea is that intervening on each of these factors, and particularly social and economic policies upstream, has the potential to influence health and inequities at the population level. So let's talk specifically about one social factor, which is poverty. So we know that in the US, this is a particularly pervasive risk factor. The US has among the highest rates of poverty compared with other high-income countries. 1 in 5 children live in poverty, which is defined as below 50% of national median income. And in fact, the US is the 34th out of 35 high-income countries in terms of the percent of children living in poverty. And we're beating out only Romania, which was only added to the list of high-income countries in the last couple of years. This figure shows poverty rates by state, and as you might imagine, this varies greatly. We have some New England and mountain states that have poverty rates below 11%, while parts of the Southeast exceed 18%. So some of you may know this famous quote by Supreme Court Justice Louis Brandeis, who referred to states as the laboratories of democracy because of the decentralization of much of social and economic policy, and we might be seeing the consequences of that here in this figure. And for anyone paying attention to the news lately, this has certainly played out over the course of the COVID pandemic. So let's start to tie this back to health. Here we have age standardized mortality rates by county, and few of you will be surprised that this maps pretty well onto poverty rates. Deaths per 100,000 population range from 400 in parts of New England and mountain states to over 1,600 in parts of the Southeast, which is a 4-fold difference. So the figure I just showed you illustrates how poverty and mortality track together. And in social epidemiology, we refer to this relationship between socioeconomic status, or SES, and health as the gradient. And this figure is obviously stylized. The relationship isn't always so linear, and there's some notable exceptions like breast cancer incidence, but the basic message is empirical work has shown over and over that this general relationship holds for many, if not most, health conditions, and for many operationalizations of socioeconomic status like income, wealth, occupation, etc. All right, so we've established the importance of social determinants of health. So the next question is, where should we intervene? You could think of intervening downstream at the individual level, for example, by providing additional healthcare to low-income individuals. You could intervene a bit further upstream, for example, by providing household resources like food or housing. You could intervene even further upstream and have interventions to increase income. And at the population level, we have social and economic policy, which would address these risk factors in a more sweeping, but maybe a little bit less precise fashion. So let me quickly touch on the utility of intervening in the clinical setting versus further upstream, and in particular, what I mean when I use the term population health. So let's say this box represents the entire US population, and just think to yourself, what percent of these people do you think are seen by a doctor in a given year? So in a non-COVID year, that figure is about 80%. And then think about what percentage might be seen by specialists. And again, in an unusual year, that's about 35%. And then what percent are hospitalized? 5% of people in a normal year. And finally, what percent are hospitalized at a academic medical center? And that's 1/2 of 1%. And this is just to point out that the term population health management that's increasingly used in medical systems actually leaves out large parts of the population, and probably those that are most in need, like the uninsured and underinsured, while social policies have the potential to target much larger swaths of the population that are much more at risk. And as a side note, when I was a medical student at UCSF during my family medicine rotation, one of the faculty members, I can't for the life of me remember who it was, maybe somebody can remind me if they know who it was, gave us a talk that used almost exactly the same figure, and it has really stuck with me through all these years as a really powerful way to show how actually relatively insignificant the academic medical system is. Okay, assuming that we've decided that we want to intervene further upstream, how do we actually intervene? So here I've drawn out a relatively simple causal diagram or conceptual diagram showing the ways that a parent's socioeconomic status might influence child health. First is through the parent's occupation or income and just the simple ability to afford food, healthcare, and other important household resources. Then there's the stress pathway, which is thought to affect health through derangements in inflammatory pathways that affect metabolic and immune function. And finally, there are differences in health behaviors like smoking or physical activity that may differ by socioeconomic status, maybe because of social norms. So for the most part, you can imagine that it's difficult to isolate the effects of many of these characteristics, either because of the feasibility or ethical challenges of randomization. And if you were just to do an observational study to look at the association between poverty and child health, for example, you won't be able to determine whether it's poverty itself that's the problem or all these other associated characteristics, or sorry, whether all of these associated characteristics are the more important determinants. So in epidemiology, we call these variables potential confounders. And this is where social and economic policies come in that they often result in variation in these social factors that's arbitrary or quasi-random, which means sort of as good as random. And we call this type of study design a natural experiment or quasi-experiment. It reduces confounding due to all, other unmeasured characteristics of the exposed and unexposed groups, often similar to the setup of a randomized control trial or RCT. So I'm just briefly, for people who are thinking about research in their future, so just going to give a brief list of the benefits of using natural experiments. So first, as I just mentioned, correlation is not causation, and we want a way to make more causal claims about the importance of social factors so that we can feel very confident in designing interventions and establishing their cost effectiveness. Second, natural experiments actually have a benefit over RCTs in that they reflect real world circumstances. They're more feasible and ethical because they don't require randomization of things like poverty and educational attainment. And they're often cheaper since you don't have to recruit and survey and follow thousands of study subjects. Of course, they also have their limitations. It's sometimes hard to identify a policy that meets the criteria of quasi-random. And you do need to be able to find a data set that includes the time period, the geography, the variables of interest. So to illustrate these concepts of what research in this field looks like and why it's harder than it looks, as I said in my title, I'm going to dive into a few of my own studies on one particular policy. That policy, as I mentioned at the beginning, is the Earned Income Tax Credit, or EITC. It's the largest US poverty alleviation policy for families with children. About 25 million families receive $60 billion each year through the EITC. And it's a federal program that operates as a tax policy. It provides big tax refunds to low-income working families. This figure illustrates how the refund size is determined. So you have increasing income on the x-axis, and we see that the size of the refund on the y-axis increases up to a certain plateau, and then it's phased out at higher levels of income. Individuals with no children get smaller refunds than individuals with children, and those are the differently colored lines. And married couples, the dotted lines, get slightly more than unmarried couples, which are the solid lines. You can see that the maximum federal refund for a family with 3 or more kids is over $6,000. And for a family with $15,000 in income, that is 40% of their annual income that they're getting as a tax refund. The EITC has another source of variation, which is that the program has been repeatedly expanded over the years, in particular under Clinton in the 1990s. It's one of the few policies that usually has bipartisan support because it provides income to poor families, which progressives love, and at the same time, it incentivizes work, which most conservatives love. And then this is yet another source of variation in the EITC, which is that since the 1980s, over half of states have begun to provide an additional tax refund on top of the federal refund. And these state EITC programs vary in terms of when they are first implemented and the size of the eligibility, their size and the eligibility criteria for the refund. Here's an example of California, which was surprisingly a late adopter and only implemented its EITC about 5 years ago. And the solid line again is the federal refund, and then the dotted line also includes the California refund. So as I mentioned, each state's eligibility criteria are slightly different, and you can see the California refund is designed to increase income for the lowest earning households, while most states actually provide a bump to the federal EITC across all income levels. So in this case, we have a lot of types of variation that result in a lot of possible natural experiments, each of which has its own benefits, but maybe also suffers from its own flaws. And what my research aims to do is triangulate or converge on the truth by studying the policy through multiple different lenses. And another benefit of this multi-pronged approach is that we can also try to understand the mechanisms through which this income supplement may operate, which I'll describe a bit more later. So let's talk about the first study in which the goal was to look at the effects of the EITC on child development. So for this study, the sample was drawn from a data set called the National Longitudinal Survey of Youth, or NLSY. And this is a cohort study that followed the same children over time. And for this study, we included the years 1986 to 2000. We restricted the sample to people with household income less than 50,000. So those are a better comparison group than those with higher income. And the final sample, we had about 3,600 women and over 8,000 kids. The primary exposure is the size of the EITC refund for which a family is eligible. NLSY actually doesn't ask participants about their taxes, but we can calculate EITC refund size based on what people reported were their income and demographics. And so we don't actually know who received the refund. So this is kind of like the intent to treat strategy in a randomized trial where we assume that everyone eligible received the payment. And in reality, about 80% of eligible individuals actually get their EITC refunds. So the outcomes were the Behavioral Problems Index, or BPI, and the Home Observation and Measurement of the Environment, or HOME score. And these are each measures of child development that the NLSY asks about biennially, or every 2 years. The BPI asks whether the child has antisocial behavior, anxiety, etc. And the HOME score captures the physical and emotional aspects of the home environment, like whether it's cluttered or dark, or whether anyone reads to the child. And both of these may not change immediately after the disbursement of a tax refund. So for each one, we calculated the difference between the current year's score and the score in 2 years, and then 4 years out from the EITC refund to capture the short and medium term effects. And then we adjusted for a bunch of different covariates in our models listed there. And the analytic method we used is something called instrumental variables analysis. This is an econometric method. It's getting more popular in public health research, and I'm not going to get into the super technical details, but for those people who are unfamiliar, I'm going to give a really simplified explanation. So it's used in cases when you have a predictor that might be challenging to randomize, like income, and when the relationship with the outcome may be confounded by unmeasured things like SES, and it relies on the presence of what we call an instrumental variable, which is not confounded by unmeasured socioeconomic status. In other words, it's sort of quasi-randomly assigned. And then any perturbation or change in income that's brought about by the instrument can be used to sort of infer the causal effects of income on the outcome, which in this case is child development. In this case, again, we know the EITC is not associated with unobserved individual factors, and we use it as an instrument for income. And like I said, I'm not going to get into the nitty-gritty details. If anybody has questions, we can talk about them in the Q&A. And so I'm just going to jump to the results for this analysis. And so what you see is a reduction in behavioral problems for kids at 2 years, and a negative but smaller and statistically insignificant coefficient at 4 years. And so this suggests that the EITC results in short-term improvements in child behavioral problems, but maybe these don't persist. And then for the HOME score, we see improvements at 4 years, and positive, which are positive but statistically insignificant. And then at 4 years, the coefficient is larger and statistically significant. And so we know EITC recipients tend to qualify multiple years in a row. And qualitative studies show that they're spending the refunds often on durable goods. So it may be that these effects are accumulating in the long run in terms of home resources. So in general, these effect sizes are about 2 to 5% of a standard deviation per $1,000, which is fairly modest, but it's actually comparable to other studies that show that for each additional year in poverty, these scores worsen by 3% of a standard deviation. And just as a side note, we also noted that there was greater improvement among unmarried women who represent a particularly vulnerable group. So these findings suggest that the EITC has important effects on child health, even though it's primarily intended to alleviate poverty rather than address health. And of course, this analysis doesn't generalize to income provided in other ways, like if you guys have been hearing about the child tax credit that was recently passed, which is supposed to be dispersed more frequently, or increases to the minimum wage. Also, the EITC may affect the outcomes through other non-income pathways. So for example, it is contingent on working. So that might either enhance or worsen family health. For example, if work is really stressful, or if it makes it such that children are left with low quality childcare providers. And finally, our study didn't get at the more cumulative exposure to the EITC or longer term outcomes, which are important to examine. So returning to this figure, we start to get a sense that income is one potential pathway to address health, although we haven't really gotten into the mediating pathways, and they're numerous. So the next study tried to test one of these in particular, which is spending on healthcare. Before I get into the study itself, I want to introduce another key detail about the EITC. So recall the EITC is a lump sum tax refund, and in this figure, we see the share of tax refunds that are received by month of the year. So J is January, F February, March, etc. And the solid line is your average taxpayer, and the dotted line is EITC recipients in particular. So namely, EITC recipients tend to know that they qualify for this larger benefit, so they tend to file their taxes earlier. So nearly 60% get their refunds in February, another 30% in March and April. And what we can do then is, and regular tax filers have sort of more delayed receipt of their refunds. So if we want to look at the short-term effects of the EITC, we can take advantage of this variation. And what we do then is compare health outcomes among EITC recipients in the spring to EITC recipients in other times of the year, further out from the refund. And then we can kind of subtract out just the underlying trends in these outcomes among non-EITC recipients. So for this study, we use data from the Medical Expenditure Panel Survey, or MEPS. And this is basically a sort of a serial cross-sectional study. It interviews new waves of participants every 2 years. And for this study, we used data from 1997 to 2012, and again, only included low-income households. And for this study, the sample was 1.2 million adults. And the outcomes were out-of-pocket spending in a given month, looking at a number of different categories. So we looked at total spending, and then we looked at office-based visits, including a couple of subcategories. And then we also looked at dental visits, emergency, and then outpatient and inpatient hospital services. So in this case, the analytic method we used was difference in differences analysis. And again, I'm going to talk through really simply what that does. So this figure is stylized. It's not based on the actual results, but just to give you an example of what we're doing here. So we split up the year down there on the x-axis into February to April, when the bulk of recipients received their refunds, and the other months of the year, the non-exposed months. And ideally during the non-exposed months, we see that the EITC eligible and non-eligible individuals, which are sort of like the treatment and control groups, have parallel trends. So the slopes are the same. And then what we might see is that during the exposure window, maybe we see this pattern with an increase in expenditures among the EITC eligible group. And difference in difference analysis basically assumes that the trends and outcomes would have stayed the same if it weren't for the EITC, and that any difference we observe is the treatment effect of the EITC. So here are the results of this analysis. And the coefficient here is change in monthly spending per $1,000 of EITC. And here are each of the spending categories along the left. And as you scan down, you'll see that we didn't find any significant effect for either total spending or any specific category. And keep in mind, this is 1.2 million people. And again, this is per $1,000, and most of these coefficients are extremely close to zero. So our sample is definitely big enough to pick up even small effects, and we're finding none. We next broke it down by insurance status. We hypothesized that the effects maybe would be stronger for those with Medicaid, which is the green triangles, or those without insurance, which is the red squares, since these people might be more resource constrained. But the results were again null for all categories of spending and for all subgroups. And again, with a sample of 1.2 million, this is pretty compelling. And then this is just for the last few outcome categories for this insurance subgroup analysis. Again, pretty much null. So what might explain these findings? It is possible that low-income people just don't spend this annual lump sum on healthcare in the short run, at least not any more so than the control group of higher income people. But just because this study's results are null, that doesn't mean the EITC isn't going to have an effect on health. Recipients may very well be spending the benefits on other resources that are actually more important for their health. In fact, as I mentioned before, some qualitative work suggests that the money is spent on things like durable goods, household appliances, other big ticket items, as well as paying down debt. And all of these may address more powerful social determinants of health than healthcare itself. So getting back to this figure about the possible pathways through which income from the EITC might improve health. So it seems like we might be able to rule out healthcare spending, at least in terms of short-term effects. And what about the stress pathway? This is an important hypothesized mechanism linking income and health, and that's the question in this last study that I'm going to talk about. So again, I showed you this figure before, but in this study, we're taking advantage of the variation in state EITC programs to look at the effects of mental health among adults. For this study, we used the panel study of income dynamics. This is another cohort study that follows the same families over time. And we were looking over a 20-year period from 1995 to 2015 at a range of mental health and health behaviors. And again, we kept the sample to low-income individuals, and the sample was about 10,000 adults. So like the previous study, again, we use difference in differences analysis. And in this case, the treatment group is states with EITC policies, and the control group is states without EITC policies. And again, it assumes that during the pre-EITC period, states with and without EITC policies have parallel trends in our outcomes of interest. And then after, let's say that we observe this change, and then we can attribute any deviation from the expected trend to the EITC policies at the state level and call that the treatment effect. So here are the results from this analysis, and this was actually just published earlier this year. So for every outcome, we found no significant effect of the state EITC policies. We again, for the study, looked at different subgroups, men and women, people who are single or married, different racial ethnic groups, and didn't find an effect for particular vulnerable subgroups either for any of these outcomes. So, okay, before you despair, poverty alleviation policies are totally ineffective at addressing health. Let me give a bit more context to understand these null results. So in our sample, the average state EITC payment size was $265, and this is received again in a lump sum at tax time. And you can look at the size of the EITC payment by state, and this table shows the size of state EITC benefits as a percentage of the federal benefit. Keep in mind that the average federal benefit is about $3,000. So in some states like Maine, Montana, North Carolina, they're providing 3 to 5%, which is about $100 on average. So you can imagine this may not have major effects on the outcomes we examined here. Unfortunately, in our study, we didn't have a big enough sample to look at the effects separately for states that have smaller versus larger benefits, but that's something that we can look at in future studies to maybe argue for increasing the generosity of these payments. It's also possible that our study suffered from what's known as measurement error. So like the study using NLSY data, PSID doesn't actually ask study participants whether they received the EITC. So we calculated the refund for each individual that they would be eligible for based on their self-reported income and demographic characteristics. And again, we know that only 80% of people actually get their EITC payments. So maybe there's some measurement issues contributing to these null results. I will point out, however, that we actually conducted a different analysis using this same data set, PSID, using sort of the imputed EITC amount. We sort of calculated it ourselves. And in that study, we were looking at the effects of the federal EITC on these same outcomes, so the bigger refund. And we did find that, that it resulted in reductions in psychological distress. So this suggests that the null findings from the state EITC analysis are not because of measurement error, but more likely because of the smaller size of the state EITC benefits. And there have been several other studies that have found positive effects of the federal EITC on mental health using other data sets. And this is an example of, again, sort of that triangulation, like using multiple studies to try to understand what the truth is and not just assuming, you know, I got one null result, therefore this policy is ineffective. That's not true, might not be true. Okay, so to put this all together, the studies I shared today found that the EITC is associated with improved child development and that the federal EITC, at least, is associated with improved mental health for adults. So these studies are adding to a really robust literature that has found positive effects on other aspects of health that I didn't discuss today, like birth outcomes, children's test scores. But we do need to be attentive to the studies that are finding null effects. They may help us to understand how the EITC is spent and whether there are aspects of the program and its design that could be improved on. So for example, would it be better if the payments were distributed throughout the year instead of just at tax time? Would we see more effects on health from larger benefits, or are people spending the benefit on non-health related inputs? And I didn't even get to the reasons behind the relatively low take-up of the EITC at 80% I mentioned, and whether there's a better way to administer the program than through complex tax filing. So the glib conclusion is that evaluating poverty alleviation policies is harder than it looks, but this information is really critical to best inform policies to address the social determinants of health. And more generally, this work is highlighting the need to evaluate even common sense policies, things wherever, you know, people sometimes say of course, poverty alleviation is going to work. Like, why are you wasting valuable research dollars looking at it? And this sort of helps justify that. Sometimes we have to be prepared for answers we don't like. And what this also demonstrates is that we need to use different kinds of variation, different kinds of study designs to get at the effects and the mechanisms to best inform policy design to really meet our goal of alleviating health disparities. So I want to acknowledge my co-authors on the studies I presented here, and I highlighted the ones where a trainee was involved when the work was done. And I also want to acknowledge the funders who supported this work. And then finally, here's my contact information, but for people who want to find out more about either the research I did today or other faculty at UCSF who do similar research, I've listed out, the Institute for Health Policy Studies, the Population Health and Health Equity Initiative, the other people in family and community medicine, and then the Center for Health Equity if you want to check out those resources to find out more about this kind of work. So I will stop sharing. And
great, thank you so much for sharing that really compelling talk, Rita. I know Ava and I both work with Dr. Hamad in a research capacity, and so we think about these issues all day. We're really excited to hear about what questions you have that Dr. Hamad could answer. To do that, there's a Q&A button in the bottom, I think, right of Zoom. So you can click on that and send them to us, and then we'll be able to pass them along.
it looks like Margot is potentially taking credit for that big figure on what counts as population and population health. So maybe it was you, Margot.
Well, I definitely taught it for a long time, but I would be honored to think that anybody remembered it after these years. That would make my decade as an educator. I think if we don't have any other questions in the chat, I'm going to take the liberty of asking one of my own, which is that so much of what you are talking about right now and your team, Rita, is incredibly relevant for what's in the news these days and what's being proposed by the Biden administration. How do we look at that with the lens of a social epidemiologist? How do you think about the changes that you see potentially upcoming? I realize that's a big question.
Yeah, I mean, there's lots of ways. From the beginning of the whole pandemic, I as a social epidemiologist, I was sort of viewing everything happening in the frame of health disparities and thinking about how, gosh, this is really going to hit low-income people, disadvantaged populations, racial ethnic minorities harder, just because they're the ones who don't have paid sick leave, especially from a policy perspective. They don't have access to paid sick leave or paid family leave. They might not be eligible for or know how to access these benefits that have these complicated applications. So they might continue going to work and be subject to infection. So from the beginning, I think it's been important to think about how the pandemic is going to have health disparities, and we totally saw that play out. And then now on, with the new policies being proposed and passed by the current administration, I think there's ways that research like this can really inform those conversations. So I was really following the child tax credit very closely because we have a child tax credit in the US already, but like the EITC, you have to file your taxes to get it. So for people who have low incomes and aren't required to file their taxes anyway, they don't file their taxes. And so then they miss out on this benefit, which is thousands of dollars. And so when I saw that for the new child tax credit, they're, for example, thinking about, having a monthly benefit, I thought, wow, that's really great. And, they're clearly drawing on the research, like the National Academy of Medicine. I think that's what they were drawing on, had this report on child poverty where they were suggesting exactly that. So really informing policies, using evidence that helps tell us how to best design these policies so that, more vulnerable communities can benefit, and we can try to shrink those health inequities, or at least avoid exacerbating them at the very least.
Thank you. That gives us a lot to think about.
Mm-hmm.
I know we have questions from the audience too. So
our first question is from Brandon Osborne, who's asking if you've examined other mediators in your model, such as food insecurity.
Yeah, good question. So I think Akansha Batra, who's a PhD student in epidemiology and biostatistics here at UCSF, she and I just published a paper earlier this year where we were looking at food insecurity and did find that the EITC improved food insecurity among kids using another one of these big data sets, the National Health Interview Survey. So definitely both my work and others have looked at other mediating pathways. I didn't get a chance to talk about all of them today, but that's definitely one that has come up as important.
We have a follow-up question that I think is a little broader as like a way to think about how to engage with policy research. This question asker was curious to hear your thoughts about the role or impact of systemic and structural racism on social policies and the social determinants of health, because they inform sort of all aspects of both the mediators that we're talking about and how social policies are created. So how do you think about using social policies to dismantle systemic or structural racism, or maybe study it?
Yeah, no, that's a great question. And I didn't get into it today, but for most of the analyses I do, we definitely look at how these policies are differentially impacting people of different racial ethnic backgrounds. So for example, for the EITC, there have been a few studies, including some of mine, that have shown that it improves health among Black participants more so than others. And we don't know exactly why that is. It might be because, again, more resource constrained due to history of structural racism, they can rely less on wealth, and so income becomes more important, and so then might particularly benefit. So I think that's a great way to identify which policies may be helping to shrink the effects of structural racism, and so the EITC might be one of them. To give a counterexample, another one of the policies I study is paid family leave. So that provides paid time off for new parents when they have a new birth or adoption of a child. And in all the states, we don't have a federal paid family leave, only states have paid family leave. And in most of the states that have paid leave policies, they don't give you your whole salary when you are on leave. They only give you part of your salary, like half maybe. And so we were curious, what are going to be the effects on health for that? Because particularly for very low income people, half their salary is just not enough. And so they might be driven potentially to go back to work sooner so they can get their full salary. And for a couple of the studies that we've done, we did in fact find that Black and some Hispanic participants did not have as good outcomes. Like their health improved a little bit after paid family leave policies were passed, but not as much as for white families. And again, because of historical structural racism in employment policies and all other parts of our system, that means that Black and Hispanic people are more likely to work in low wage jobs. That means that they're less able to benefit from policies like paid family leave. So absolutely, I think this area is like really has a lot of opportunity to address that.
We got another question in the chat about the growing level of state policy importance for either mediating federal policies and their impact, or polarization between states about sort of clusters of policies. Mm-hmm. So could you talk about another sort of state policy that maybe could advocate for in California, or thinking about that is sort of a focus of research right now, or you think is a fruitful place for intervention?
Can you say that one more time?
Yeah, so if we're thinking about—
There's a lot of places the questions are coming in, so I can't tell which one.
Yes.
So do you mind restating that one?
Yes, so if we're thinking about states' roles in, say, adding to federal policy, or increasingly how polarized states are in their sort of policy prescriptions for social and health problems, EITC is a big place where states can play a role in expanding, say, financial benefits to families. Is there another state level policy besides paid family leave and direct income payments that your lab is thinking about particularly right now?
Yeah, so I mean, one of the most obvious that comes to mind is the minimum wage. I don't study the minimum wage as primarily, but for people who've been paying attention, that's been a huge conversation at the federal level, just because the federal minimum wage, I forget exactly what it is right now. It's like $7.25 or $7.50, some like abysmally low number. But states are allowed to set a higher floor than that, and some have set, much higher floors. And so that's another way that it's a really uneven playing field when it comes to income support for families. And I mean, it's just sort of across the board. The idea of polarization, that there's states that have, I think you used the word bundles of policies, totally, that there's states that have just passed generous policies in a lot of different domains, and then other states, Medicaid policy, paid family leave, as I mentioned, the COVID policies, definitely unemployment insurance, how easy it is to get unemployment insurance. The fact that there are these very disparate policy landscapes, I think contributes a lot to that figure we saw at the beginning, where there's huge differences, not just in mortality, but a lot of health outcomes because of that.
Thank you for that answer. So I'm gonna combine two questions. Someone was asking, well, if the tax credits or EITC have an effect that's so small, how do you make a quantitative case for expanding them? And then, as kind of a question to go along with that one, is what would one say to policymakers or decision makers about the EITC and similar programs, and whether or not they should expand them?
Yeah, so one of the things I mentioned was that it's important to rely not just on the results of one study, obviously, but lots of studies. And so there have been more and more studies coming out every year that look at the effects of the EITC on all different health outcomes. And, unlike like a clinical intervention, like a blood pressure pill, where really plausibly the main outcome you're going to be examining is high blood pressure, for something like an income policy, there's just like such wide-ranging effects on what it could potentially impact. And if you don't go study that, you're going to miss potentially some of its positive impact. So, I'm just like giving an example of the different kinds of outcomes that have been shown to be affected by the EITC, like like head abuse and child trauma. I think I saw one recently on like intimate partner violence, that it increases access to housing, that it decreases deaths due to drug overdoses. So that even if a given study shows like modest effects on a given outcome, it's missed that one study isn't speaking to the much broader literature of all of the health outcomes. And, it may be in a clinical setting, like changing your patient's blood pressure by 3% of a standard deviation isn't a lot. But if you can imagine doing that at a population level for millions of people who are accessing this benefit, that really has the potential to shift, the entire distribution of disease and narrow the gap. So that was the first part of the question. What was the second part? What would you say to policymakers? I mean, I think, I'll say what has been said to policymakers. So again, thinking back to this National Academy of Medicine report on child poverty, there was a lot about increasing the size of the benefit. But then the other thing that I sort of hinted at throughout my talk is that the EITC is contingent on people working. And if somebody is employed or unemployed, either because the labor market is crappy, or they have an infant at home, or they have a disability or anything, they can't take advantage of the largest poverty alleviation program in the US. And I think that's where there have been policy recommendations, actually like the child tax credit, that's not contingent on employment, that people can just get because we know that there needs to be some sort of basic living standard, and that the government can help people achieve that. Like, again, minimum wage, like, great, let's increase the minimum wage for people who aren't working. That doesn't do anything. Paid family leave, great policy, but it's paid family leave from employment. So if you're not working, can't benefit from that. So I think that that's a huge gap right now, is benefits for people who are unemployed for whatever reason. And I think that that's sort of hopefully the direction that the new administration will go.
This has been a fantastic discussion. I think we have time for one more, maybe very quick question, and then we're going to wrap up.
Since we know we have a bunch of clinicians on this call, we got another question about communication, but maybe how do you communicate to clinicians about the importance of these kinds of findings to their practice? Or maybe how do you think about it in your own practice?
Mm-hmm. Yeah, so part of the way I communicate, hi everybody, is through sessions like this where what I hope to do is help people think about things that may be impacting their patient's health that are not in their direct control as their doctor, or not potentially in the patient's own direct control when they're influenced by all these structural factors and limitations and what they can and can't do. As I mentioned, the EITC, only 80% of people who are eligible take it up, and it's actually way worse for a lot of the other safety net programs like food stamps and WIC. And so thinking about integrating ways to increase take-up of those safety net programs to get more money in your patient's pocket, either through integrating with social workers embedded in clinic, or partnering with organizations that help with tax prep, and really sort of have partnerships with other community groups, particularly for people who are seeing patients from disadvantaged backgrounds. I think that's one of the key takeaways, that there are potential synergies there.
This has been a fantastic, fantastic session. I really want to thank Rita, Ava, Gabriel for all of their help, for bringing us down this pathway, which is hopefully just the beginning of a greater discussion for all of us. If you're interested in getting more involved, there are some great links that Rita shared for us in the last slide. And if you have feedback on this session, unfortunately, it looks like I'm told that we pasted the wrong links for the feedback into the chat, but we will send out an email where you can provide session feedback for the speakers and also suggest other topics for grand rounds if you're interested. And then last but not least, I want to do, for everyone who joined us late, a commercial for the next FCM grand rounds, which are going to be with Dr. Ina Park the first Friday in January, and in June, she's going to be talking about her new book, Strange Bedfellows, Adventures in Science, History, and the Surprising Secrets of STDs, which should be interesting. And then also I hope that we will see all of you and that you will join us for the UCSF Family Medicine Rodnick Colloquium on May 27th, also remotely. So thank you so much to all of our presenters. Thank you for joining us. And we really appreciate all of your insights and wisdom. Have a great day.